Today, we're getting under the hood of women's health with Dr. Creatura, a NAM certified menopause expert, sex educator, and reproductive freedom advocate. She is the founder and owner of her private practice of gynecology, menopause, and sexual medicine, and is a clinical assistant professor of obstetrics and gynecology at Weill-Cornell Medical College, and the only full-time New York City-based gynecologic fellow in female sexual medicine certified by the International Society for the Study of Women's Sexual Health. Dr. Creatura will get under the hood of abortion.
Everyone needs to know that abortion is part of normal healthcare and that everyone has a relationship to abortion. We're all abortion beneficiaries. And if you doubt that this is true, I'm going to ask you to probe carefully and understand that there are generations of stigma and shame surrounding sex and reproduction that impact this discussion. Ask your family members and look into your history to discover how abortion may have helped you achieve a healthy, holistic life with intentional child rearing and freedom to make decisions about your body. While I'm an abortion provider, I'm also a beneficiary, and I couldn't have had my healthy family or career or economic and emotional security without access to abortion care. This is not strictly a women's issue. Men need to know how abortion serves them so they can become involved in supporting access and justice and care. If you're a person walking this earth, you have been affected by someone's pregnancy care. My colleagues and I perform abortions and deliver babies for people of all religions, all political parties, those that call themselves pro-life, families of judges and politicians who lie about it publicly, because our job is not to judge, it's to meet patients' needs. And the question of when life begins is not the central issue. It distracts from the real issue. When do we think it's acceptable to force someone's body to be used in the service of another against her will? The answer should be never. Using terms like elective or choice really implies a marketplace of options in which women's rights to determine what happens to our bodies is legally protected. I feel like this ignores the fact that even with Roe intact, one's race or unfavorable geography or economic and institutional constraints really restrict their options. So talking about abortion as a choice doesn't really consider the reality in which pregnant people try to exercise their right to care. It frames women's autonomy as a luxury and bodily autonomy as expendable. So a woman who needs an abortion for economic or health necessity really doesn't experience this as a choice. It's not a choice if you have to do it to survive. So we have to be careful with language. Anti-abortion extremists are deliberately misleading in that they use terms that intend to confuse and create stigma, like pro-life and pro-choice and pain-capable pregnancy laws and crisis pregnancy centers and late-term abortions. This is all nonsense. We went to medical school to improve people's lives and treat people for whom abortion is life-saving. It doesn't have to be life-saving to be necessary and worthwhile. We all suffer consequences when people don't have access to safe abortion. We just experience those effects differently. So exceptionalism provides cover for legislators who pretend that there aren't any conflicts with the law and our ethical responsibility. It shifts the blame to healthcare providers and pregnant people when politicians assert that women aren't suffering because they have exceptions. The legal department really can't determine what's medically necessary. Unless you're caring directly for patients, you're not equipped to make rules about care. Most abortion regulations undermine our medical expertise and disregard our patients' experience. Pregnancy legislation is often kind of a naive expression of a failure to understand the biology involved, and exceptionalism really provides cover for legislators who pretend that there are no conflicts with the law or our ethical responsibility and shifts the blame to healthcare providers. I can't legislate a clinical scenario, believe me, we can't. The medical and the legal chaos from all these exception laws have repercussions. Catholic hospitals have ethical and religious directives that impose limitations on services that they provide that are in direct conflict with provision of evidence-based care, but they only apply to women. So these entities are shielded in the discrimination against women if they can say they're basing it on their religious views. We get IVF exceptionalism, we get sexual assault and incest exceptionalism. Women who wanted kids, they deserve their abortions, whereas women who just don't want to have baby, women who feel like they want to determine their futures, they're not valued, even though the procedures, the embryo destruction, the misogyny is the same. We are so accustomed to misinformation about pregnancy and sexuality, we don't even recognize the brutality towards women that's so deeply ingrained in the culture. All reproductive decision making has to center the person's bodily autonomy, no exceptions. One is a medication abortion and one is a procedural abortion. And until the last 10 years, the procedural abortions made up the majority of pregnancy termination procedures. In the last 10 years, the medication abortions have increased tenfold from 6% to well over 60% of the abortion procedures that occur in this country. So we base which procedure to perform based on gestational age, the medical history, the patient's condition, her location, where she's living, what her preferences are. And the medical abortion can be performed outside the medical system. That's called self-managed abortion, or within the medical system with guidance of a medical provider, most of whom are doctors, but some of whom are advanced practice clinicians like physician's assistants or nurse practitioners. So it's a nice procedure where you have two medications. One is mifepristone. This is a drug that is an anti-progesterone. This means that it blocks the receptor for the progesterone so that the pregnancy tissue can't continue to grow. The second drug is called misoprostol, and this drug is more widely available and not as restricted. And it is a drug that is a prostaglandin, which means that it causes the uterus to contract and allows the uterus to expel the pregnancy tissue. So these two medications can be used in sequence. The second drug can also be used alone and is very effective at ending a pregnancy, but not as effective as using the two drugs together. The procedural abortions, which are often called surgical abortions, make up a little less than half the procedures in this country now. And those procedures are, you can define them as surgery if you wish. I'd just like to point out that it's not involving any cutting or sewing. It's a procedure that a medical professional performs, and it involves using a dilator or an instrument to open the cervix, which is the opening to the uterus, and put a suction catheter into the uterus so that you can remove the early pregnancy tissue. This is usually done in a situation where we can use some local anesthesia to the cervix or some intravenous sedation to provide comfort for the patient. The medical abortion is usually done just with medication that the patient can take for cramps or for pain. The decision to choose one or the other is usually up to the patient. There are some providers who, for various reasons, may do one or the other, but generally, both options are available to patients, and many patients choose to do a medication abortion because they like to control when they're going to take the medication. They like the idea of privacy, having the procedure happen in their own home. The other abortion procedures that are performed for about 5% of the abortions are variations on the surgical procedure or even variations on the medical abortion procedure, which means we can use different instruments that allow us to open the cervix enough to remove a fetus. We can use medications that help induce a miscarriage and induce the ending of the pregnancy. And those procedures are performed in a variety of circumstances. So it would take me another hour at least to explain all those conditions, but I would say that it's really, really important to normalize that nearly 95% of the abortion procedures are first trimester and that they involve minimal complications. They're not difficult to provide, we have the technology to make it safe. When I started out, I only did procedural abortions because there was no medication abortion. So because I had such good experience providing surgical abortion care for my patients, I had a preference for surgical abortion, particularly for my younger patients, because I think that the experience of having a miscarriage, of passing pregnancy tissue, even just having heavy bleeding and cramps was more traumatic for a young person than for a person who's already been through labor and delivery. I would say that because the majority of women who have abortions are already mothers, most of those women have experienced childbirth and all of its bloody torture and pain. So they don't find it shocking to have pain and bleeding at home. Whereas if you have a teenager who's never been pregnant before, she may be in a situation where she doesn't have the support she needs, that experiencing pain and bleeding at an unpredictable, undeterminable time is much more difficult. So it's the opposite of what you might think. And again, every person is different. So just like if you're going to do an operation for someone, you might tell them there are different treatments, there are different approaches, there are different medicines to treat your hypertension. There are different ways to end an early pregnancy, and good physicians are going to explain those options to patients. And hopefully in an ideal world, patients have options so that they can choose the one that's best for them. Like any hormonal transition, ending a pregnancy affects the brain, and the brain controls everything. But it's important to point out that the most prevalent emotional effect reported by patients after their abortion is relief. Some people experience mood swings that are associated with a decline in hormone levels. Because whenever people discuss abortion regret, we talk about like people regret all kinds of life decisions, right? People regret everything that they do. But this is temporary and usually not as severe as the hormonal shifts that are experienced after a term pregnancy. Remember that postpartum depression, even suicide, is much more common after a term pregnancy than after an abortion. And safely ending a pregnancy is not correlated with any long-term serious health effects. Yet studies have shown that women who have access to care when they need it are less likely to live in poverty and have higher educational attainment, as do their children. I believe that we have to empower women to make informed personal decisions about their lives and about their healthcare, and it's our job to center the patient's needs and counsel her about any risks and benefits of any of her decisions. That's how responsible reproductive healthcare providers, free of legal constraints and cultural stigma, deliver care. I mean, banning abortion doesn't make it go away, right? It just decreases safety and it increases maternal and infant mortality and morbidity. We've seen this across the country where abortion bans have been enacted. We've made abortion care safe medically, but laws that restrict abortion make it less safe. So the underlying implication of abortion bans is that women can't be trusted to make their own healthcare decisions. And this distrust extends to healthcare providers when legislators spread misinformation. Abortion bans create a class of persons for whom fundamental constitutional rights no longer apply. And they force doctors to be complicit with the government in a forced intrusion into the bodily autonomy of another person. Abortion bans arise from a fear of female sexual agency and a deeply ingrained cultural entitlement to women's uncompensated labor. But bans on any healthcare, most importantly, impacts all healthcare because providers and trust, access, staffing, nobody wants to be isolated in a state with substandard medical care. The criminalization of abortion care silences providers. It forces us to engage with the injustice system. Just consider the moral injury that's suffered by healthcare providers from being forced to deny their patients life-saving care. We can't comply with the law and uphold our professional obligations to our patients, who should have a right to factual, compassionate, evidence-based care. Restrictions on reproductive options have downstream effects that are not understood by those who enforce the rules, but they have the potential to be felt by everyone. When healthcare becomes a partisan issue, everyone suffers. We saw this with COVID misinformation. We should have learned it. The removal of the protections of Roe is now presenting the country with a disturbing seminar on obstetrics, on the true impact of pregnancy and birth complications. Banning abortion arises from a cultural entitlement to women's uncompensated labor. We don't value the risks undertaken by women in producing humans. And when a culture feels entitled to women taking on this burden and it can be forced upon her, it truly constitutes government endorsed gender violence. State sponsored torture should be constitutionally prohibited, at least in a world in which we could trust our highest courts to enact justice. But this can only happen in a world in which we deny that pregnancy is always a health threat. The essential problem is the negation of the value of a person's gestational labor and the reluctance of the culture and the scientific community to quantify the immediate and long-term impact of pregnancy and birth. There is no moderate position on banning abortion. Just imagine a world in which women can get what they need. Just think about connecting abortion with health equity. So we need to do that. We need a public health infrastructure, right? With adoption of a national policy that prioritizes pregnant people's needs, which integrates principles of justice and equity into pregnancy care and into policies around childcare, parental leave, comprehensive sex education, safe environments to raise children free of violence, poverty, pollution. We have to liberate abortion from legislative interference. The Women's Health Protection Act asserts a federal right to care and that precludes states mandating cruelty in healthcare, which is what the current post-obs scenario has created. So regardless of state or party, the majority of the US population prefers autonomy in healthcare decisions and doesn't support banning abortion. So we have to trust women to be experts on their own lives and pregnant people to make their own healthcare decisions. The medical establishment has to speak out. Our silence on this issue is allowed terrorism. Healthcare systems have to counterbalance the anti-abortion rhetoric that threatens people's access to just pregnancy care. And finally, we need to study and quantify the true long-term impact of pregnancy and birth. And this would ensure that all pregnant people have timely access to information and providers that can help them. We have to recognize that the ability to decide whether or when to have children is a key to economic success and survival. It's the most powerful gender equalizer of all. I think that, as I said before, I think it's really important that we all acknowledge that we're all universal abortion beneficiaries. And this is something that makes people's opinions change, because the shame and the stigma has kept people from learning their history. And what's interesting for me as a provider is that all the years I've been doing this, when I tell people that I'm an obstetrician and gynecologist, and they learn that I also provide abortions, because that's part of what we do, that people tell their stories. And they tell their stories, and sometimes the story ends with, "And you're the only person I've ever told." So I feel like that shame and the pain that people experience because they aren't going to tell the story to somebody who they think will stigmatize them or hurt them is something that we want to liberate and normalize. And when I say that men need to understand their history, it's because, as you know, men are responsible for most pregnancies. They need to know that they benefit when we're able to end them. They need to know that they benefit when their partners don't die in childbirth because there are no obstetricians around to take care of them, that their family members have access to evidence-based care that's not tied up in somebody else's religious morality. We all need this. And I think when people get to pretend that abortion doesn't really affect them, that it allows them to not consider it when they vote. What we have to do right now, which I think finally losing the protections of Roe has allowed so many more people to understand, is that abortion care impacts everyone, the whole culture, every one of us.